Good morning, everybody. This is Cam Kalontar from University of California, Irvine. I'm one of the practicing nephrologists and faculty members at the University of California, Irvine, or UCI, in Orange County, around a 30-40-minute drive from here. I'm privileged and honored to chair today's session in the morning, and followed by also my own presentation around noontime. So if you're thinking of leaving early to the airport because you have flights to catch, please change your flight schedule to stay for my talk. So having said that, I'm privileged to chair this morning's session. We have a number of nationally and internationally renowned experts and opinion leaders, including nephrologists and other experts who are going to present today. The first presentation, the first talk is by great colleague and friend, Dr. Nigwekar, who is a full-time faculty member at Harvard Medical School, Massachusetts General Hospital. Dr. Nigwekar is currently assistant professor of medicine at Harvard Medical School and practicing physician, assistant physicians at Massachusetts General Hospital, or Mass General Hospital. He is renowned for a number of areas. While being a practicing nephrologist, he's also an expert in vascular calcification and calciphylaxis. He co-chairs the International Consensus Panel on Calciphylaxis. His training includes nephrology fellowship at Harvard Medical School, combined Brigham Women's Hospital and Mass General Hospital, and he has contributed tremendously to the field. If you are nephrologist or nephrology investigator or affiliates, you should know that calciphylaxis happens, including even last week at UCI, we had 2 patients, and one of them in a relatively serious condition. So I would like to ask you to join me to welcome Dr. Nigwekar and his talks.
Good morning, everyone. Thank you for this kind invitation to share my thoughts on this rare but devastating disease known as calciphylaxis. As Dr. Kalontar today was suggesting, this is an entity that has been around for a number of years, but unfortunately, even today, we do not know much about it in terms of its pathogenesis, biology, and as a result, we do not have an approved therapy to offer to our patients with confidence. Having said that, there have been a number of updates in the recent, I would say, 5 to 6 years that I will share with you. And it's really exciting as a young investigator in this area to see now not just the epidemiological data, but also clinical trials entering this space. So I think hopefully in the next few years, we will have some definitive answers in terms of what to use for these patients, both in terms of newer or novel therapies, but also some of the some off-label use of currently available therapies. What I would like to do in the next 30 minutes or so is to give you a story. And I know there are a number of trainees in the audience here, and share with you the importance of publication or reporting, especially when it comes to rare disease pathology. So on the left side, top part of the left side is a case report that I put together during my residency, and it was reviewed but actually not accepted in any of the nephrology or even non-nephrology journals. Finally made it as a letter to the editor in one of the internal medicine journals. This was a patient I saw, and I will never forget. I was on medical service. I had a woman who had diabetes, had normal kidney function, but had non-healing painful leg ulcer, which was biopsied. And I remember getting a call from the pathologist asking me, who is the nephrologist following this patient? And I said, why nephrologist? As far as I can see, as an intern or a resident, this patient's kidney function based on creatinine seems to be normal. And the pathologist said this woman's biopsy that I just reviewed has calciphylaxis. That's the first time I heard this term. I had no idea what that entity meant. But nevertheless, I called the nephrologist, who was equally surprised to find this woman with normal kidney function have the pathology of calciphylaxis. Long story short, we reported this patient. This woman turned out to have primary hyperpara, and that was driving hypercalcemia. And in the background of calciphylaxis, likely precipitated calcium hydroxyapatite in the microcirculation of her cutaneous blood vessels, and then resulting in calciphylaxis. She actually did pretty well with parathyroidectomy. She completely recovered in terms of that non-healing leg ulcer. And we have moved that story forward now over the last, I would say, decade or so, all the way up to a couple of years ago, where I was invited to write a review article summarizing the recent literature on this topic of calciphylaxis in the New England Journal of Medicine, and will provide you with some novel insights as the field is thinking about in terms of the pathobiology of this disease. So the objectives are to discuss clinical presentation, pathogenesis of calciphylaxis, outline the currently what has become like a standard of care approach in terms of the multimodal interdisciplinary team for calciphylaxis management. And most exciting part for me, at least as an investigator, is to share with you some details about the clinical trials in this space. Of course, it's been challenging considering how sick these people are and how rare the disease is. But finally, I think the field is moving to the point of having a consortium network of investigators, patients, caregivers, and a variety of other stakeholders, including the FDA, to have some clinical trials and real evidence for our patients. So I'm going to start with this question, and I think you have the audience response system. This is a 52-year-old woman with end-stage renal disease, secondary to diabetes. She's on peritoneal dialysis. She has developed this painful, indurated skin lesion involving the abdominal wall. She has a prior history of subtotal parathyroidectomy. Her laboratory features are in front of you: calcium 7.8, phosphate 6.4, PTH 27, albumin 3.2. Medications are calcium carbonate and calcitriol. And the question is, what's the most appropriate treatment of her mineral abnormalities? Cinacalcate addition, surgical parathyroidectomy, aluminum hydroxide, paricalcitol, or sevelamer. Great, at least good to know some of you have had coffee this morning, so people are participating. Okay, so I guess as you see, the most preferred answer on this slide was parathyroidectomy, which I would argue is not the right answer. I would select adding non-calcium-based phosphate binder, for example, a sevelamer, to manage her phosphate. As you saw, her PTH was already suppressed, and there's an argument to be made that she may have likely a dynamic bone disease in the context of PD as well as maybe diabetes. And by doing something like surgical parathyroidectomy, she may be at a high risk not only for hungry bone syndrome, but also probably more progression of vascular calcification, because a dynamic bone will predispose her for progressive vascular calcification. Same thing with cinacalcate. You don't want to over-suppress PTH in these individuals. In our protocol, clinical protocol, we try to aim for a PTH level between 150 to 300 for most of these patients. I, of course, I don't want to let the PTH rise too high, but also over-suppressing PTH may not be the best idea for these patients. And obviously, as you will see through this presentation, calcium, vitamin D compounds are generally to be avoided in these patients, especially considering we have safer options to control their PTH or phosphate or the calcium levels. So what is the current definition of calciphylaxis? And we have been debating this as experts in the field for a number of years at this point. What is summarized on this slide is the current understanding. So it's a disorder of microvascular calcification, occlusion, likely secondary to thrombosis, that leads to painful skin lesions. And unfortunately, patients have severe implications in terms of morbidity as well as mortality, with average one-year mortality reported as 50 to 80% in these patients. The vascular bed that is involved in this condition is are the blood vessels that are in the subcutaneous areas very close to the adipocytes. So when if you are doing a biopsy, it needs to be deep enough to get to that subcutaneous adipose areas. At our site, we have developed a technique of a punch biopsy with a telescoping technique, where the first punch is placed, which goes around 3 or 4 millimeters deep, and the second punch is introduced through the first punch to get to additional 3 or 4 millimeter depth. We feel that this procedure is way safer than doing the wedge excision biopsy, which is frequently met with complications of non-healing ulcers as well as infections. As you can see, the clinical manifestations can be quite variable, but pain is almost always one of the primary and the most dominant feature of this condition. Pain is frequently moderate to severe in intensity. It is somatic in nature. It may have a little bit of a neuropathic component, and unfortunately, in many individuals, does not respond to strong analgesics, including opiate medications. Early in the course, the lesions may be quite benign looking, simple redness, simple livido, simple purplish discoloration, simple nodule, but have a tendency to very quickly progress and become ulcerated lesions, as shown in some of these images. The lesions tend to aggregate around the areas of adiposity, so lower abdomen, thighs, breasts in women, buttocks are more likely to be involved than more distal body parts. Although, as you see in these images, distal calciphylaxis is well documented. These patients, of course, frequently have diffuse cardiovascular calcifications. So not just in the subcutaneous adipose areas, but they may have coronary calcifications, carotid calcifications. As you see in panel J there, the femoral artery seems to have almost the same density on the plain X-ray as the femur. The pathology, as you see in the histology panels, K and L is the involvement of those subcutaneous arterioles next to the adipocytes. And the features that the pathologist is looking for is not just calcification, but also thrombosis and the intimal hyperplasia. Calcium deposition is also described outside the blood vessels in these patients, and typically involving the periadnexal tissue, such as the sweat glands. Of course, majority of the patients who develop this complication have advanced kidney disease, but the disease has been described in individuals with normal kidney function or maybe mild or moderate CKD. The table on your left is summary from Mayo Clinic experience, where you can see 70% or so of patients had advanced CKD, and the remaining had either no CKD or milder versions of CKD. The disease is way more predominant in women compared to men. So in this series, 80% of individuals were women. I will come back to the warfarin story in more detail, but as you see on this slide, 60% of the participants in this study had exposure to warfarin prior to developing calciphylaxis. The table on your right lists many other risk associations that have been described in the context of calciphylaxis. And these are, of course, associations. Causality for some of them has not been confirmed, with the exception of, I would say, warfarin, that I will hone in on in some of my subsequent slides. It's fascinating to see the frequency of this condition varies across the globe. And I think we have a lot to learn from our colleagues, especially from Japan, because where the incidence of calciphylaxis is remarkably lower compared to what we see in the United States. So recent data from the US, the frequency among hemodialysis patients, 3.5 new cases of calciphylaxis for every 1,000 patient years. And that number drops below less than 0.1 in Japanese chronic dialysis patients. There is a suggestion that in peritoneal dialysis patients, the frequency may be slightly higher than hemodialysis patients, although I would probably caution that in our series, at least when we have looked at this question, many patients who developed calciphylaxis while they were on peritoneal dialysis had arrived to peritoneal dialysis after failing hemodialysis, and the transition was made because of indications such as hypotension or axis abnormalities. So I don't really think that it's a dialysis modality per se, that drives this disease, but maybe some of the associated factors that may be more driving this phenomenon. For whatever reason, it may be awareness or it may be true change in the biology. At least in the US, there seems to be a bit of an uptick in the frequency of calciphylaxis, and that those data were collected through the administrative database, such as the US RDS. So those are billing, those data are primarily based on the billing information, so there are limitations, but that is what we have as the current data. So during fellowship, under Ravi Thadani's mentorship, we started asking fundamental questions. What is actually deposited in the skin tissues of patients who have calciphylaxis was one of the main questions that I tried to answer during my fellowship. And through a variety of experiments, through the tissues that we started collecting as part of our calciphylaxis registry, we interrogated those tissues with micro CT scans and Raman spectroscopy and identified that the deposition, the crystal that is getting deposited, is actually calcium hydroxyapatite, calcium combined with phosphate in a molar ratio of 1.6. And why is that deposition happening? And of course, one of the possibilities, and I think the field has thought a lot about this in the last 20, 30, 40 years in terms of the drivers of calcification: phosphate, PTH, calcium, vitamin D. And of course, I'm not going to say that those are not important, but I think likely more important is the lack of calcification inhibitors. So in the body, there is of course tendency to calcify, but as we sit here in this room, we are not having diffuse vascular calcification developments because all of us have these endogenous inhibitors of vascular calcification. And three main inhibitors that we have highlighted in this cartoon is one is matrix GLA protein, which is a protein that is produced in the chondrocytes and endothelium. It's a very interesting protein. It's a protein whose job is to prevent vascular calcification, but for its activity, it does require vitamin K as a cofactor. So MGP, or the matrix GLA protein, when it is produced in the body, is inactive, is useless. It's only when it gets activated or gamma carboxylated, it can actually deliver its job, which is to inhibit calcification. But that activation is dependent on vitamin K. Very similar to the clotting proteins, which are made in the liver, but when they're produced, they're useless. It's only when they get activated with vitamin K as a cofactor, they can actually do their job. So of course, we use warfarin as a vitamin K antagonist because it traps the vitamin K in the cycle and doesn't make it available for the protein activation, and blood remains thin, which is great. Unfortunately, there could be adverse consequences of that therapy, which one of them could be this lack of activation of matrix GLA protein, leaving patients with an unopposed risk for calcifications. There are two other calcification inhibitors that have been studied in our laboratory and other laboratories in terms of their role in calciphylaxis prevention. One is fetchine A, which is protein made in the liver. It's a circulatory calcification inhibitor. And a third one is a local calcification inhibitor known as pyrophosphate. And I will, again, the most data we have at this point is for MGP, matrix GLA protein, and that I will share with you in the next few slides. So the idea about this MGP was driven by a number of epidemiological studies, and that's really epidemiological studies, especially for rare diseases, are extremely important. Those early observations that a physician or a scientist makes from the bedside available data can be really transformative in terms of guiding the subsequent investigation of biology and treatment and the prevention strategies. This was one of the largest case control studies for calciphylaxis risk factors, where we identified over 1,000 dialysis patients in collaboration with investigators at the Fresenius Medical Care North America, matched them with controls who did not have calciphylaxis, and asked the question, not at the time of development of calciphylaxis, but 3-4 years before an individual developed calciphylaxis, how did that individual look different from somebody else who did not develop calciphylaxis down the line? And one of the striking observations, although we were not the first one to report this, but the strength of our study was the large sample size. And as you can see here, dialysis patients who were exposed to warfarin therapy had over 3-4 times higher odds of subsequent development of calciphylaxis compared to those who did not have warfarin exposure. Of course, calcium, phosphate, PTH also did show up as potential predictors of subsequent calciphylaxis, but the magnitude in terms of the odds ratio in terms of a single predictor was one of the strongest for warfarin. This cartoon just summarizes the biology that I was highlighting before. Matrix clot protein needs vitamin K dependent activation for its job to do calcification inhibition. And as you see in the vitamin K deficient state, either because of warfarin exposure or because of some other cause of vitamin K deficiency, that activation does not occur, and patients may be predisposed to vascular calcifications, including cutaneous microvascular calcifications. So these are relatively, I would say, limited data because of the sample size, but still probably one of the largest experience we have, where we have shown that patients who developed calciphylaxis, almost all of them had vitamin K deficiency. And you may say, you know what, maybe that was because they were on warfarin. But the panel on the right is actually comparing patients who were not taking warfarin. And even in that group, you have cases in the red, controls in the blue. Cases have much higher prevalence of vitamin K deficiency, measured by a very sophisticated assay for vitamin K deficiency known as PIVCA. Now, controls are also frequently vitamin K deficient, and controls here are dialysis patients who did not develop calciphylaxis, and they were matched to cases in terms of their age, sex, race, and warfarin exposure. Vitamin K, of course, comes from a variety of sources. The most dominant circulatory form is phylloquinone or phytonadione, which comes from green leafy vegetables, plant oils. There is also some vitamin K2 forms like menaquinones, which come from animal meats and dairy products. And of course, as you can see, we focus on a number of parameters in dialysis patients, potassium, phosphate, which of course are highly important, but inadvertently we may be introducing deficiencies of other micronutrients such as vitamin K when we tell our patients to avoid dairy products or don't take green leafy vegetables because of restrictions on potassium or something else. So we'll have to be a little bit careful going forward. We of course are not there as a field to say that that's a wrong strategy, but definitely makes me pause a little bit when we make those dietary recommendations. More importantly, in that same case control experience, we saw that the active MGP levels were remarkably lower among patients who developed calciphylaxis compared to those who did not. And again, that relationship was not just seen in all individuals in that case control experience, but even in the subgroup of patients who were not taking warfarin. So you may ask, why are these patients who are not taking warfarin have vitamin K deficiency and also this MGP activation lowering? I do not have the answer. Was it dietary? Was it absorption issue? Was it gut microbiome? Was it something else? I don't know at this point. Having said that, few of the patients who developed calciphylaxis in this experience and did not have warfarin exposure had undergone previous gastric bypass surgeries, like the Roux-en-Y surgeries, and I wonder whether the anatomical manipulation may have led to malabsorption and malnutrition and leading to some of these complications. But pure speculation at this point. And this is not just a circulatory problem. Now, although we have not been successful in staining the skin tissues for active and inactive MGP, we have looked at the downstream factor known as bone morphogenetic protein and the PSMAD levels, and we have demonstrated that the PSMAD activity is increased in the cutaneous tissues of patients who have calciphylaxis compared to controls. And this biology is actually very similar in both uremic and non-uremic calciphylaxis patients. We have moved this story forward, and these are we started a clinical trial where we started supplementing patients who had uremic calciphylaxis with high-dose vitamin K. We chose phytonadione 10 milligrams 3 times a week post-dialysis, and this was a late-breaking abstract at the recent ASN Kidney Week, where we have seen some early data suggesting that this therapy will increase the activity of MGP and potentially may have some clinical benefits. Of course, this study was not planned to look at the clinical benefits. It was planned more of a proof of concept feasibility study with the biological endpoints, but nevertheless, we did see some clinical potential improvements in the clinical outcomes, such as pain intensity, lesion size, and the lesion surface area, as highlighted in that figure. But you may wonder, there are so many, I walk into any dialysis unit, there are so many patients there with high phosphate, high PTH, on warfarin, obese, diabetic, and of course, majority of them are never going to develop calciphylaxis, which is a great news. But then what is it that really distinguishes those who do from those who do not? And although we don't have full answers yet, some of the early insights suggest that one factor could be recurrent skin trauma, such as it may be induced by therapies, including something like insulin injection. So in this case control study, patients who were treated with more frequent insulin injections had higher odds of subsequent development of calciphylaxis compared to those diabetic patients who were not taking insulin injections. And in this experience, we only focused on the areas where insulin injections are typically administered, lower abdomen and thigh areas. Again, epidemiology at this point, we don't have corresponding biological data. So let's do the next question. This is a 66-year-old woman with end-stage renal disease on maintenance hemodialysis. She has now painful reticulate purpura on thighs. She has chronic AFib, for which she is on metoprolol and warfarin. Skin biopsy shows indurated lesion, or skin biopsy with indurated lesion shows calcification and thrombosis, and fine stippled calcification was noted in the periacrine glands. The question is about her prognosis. Does the calcification suggest that she has worse prognosis? Does the thrombosis indicate that she has worse prognosis? Is the one-year mortality for patients is less than 10%? The location, does that influence her prognosis? And the non-ulcerated lesions, do they have better prognosis than ulcerated lesions? Okay, so we are all over the map, which I think gives me makes me understand that there is a debate, but also the right answer here is the last one there, which is the non-ulcerated lesions have superior prognosis compared to the ulcerated lesions. The histological definition, the criteria like calcification, thrombosis, have not been linked with prognosis in these individuals. In general, patients who have more distal lesions below the knees, away from the elbows, have better prognosis than patients who have proximal lesions, and men tend to do better than women. So what about the adipocytes? We have been talking about this, but do we really have some proof of concept here to suggest that adipocytes are playing a role? So these are some of the really, I think, informative data from Sharon Moe's group, where what she did is she exposed the adipocytes in a petri dish to high levels of phosphate, and adipocytes calcified. Of course, until then, investigators had exposed other cells like smooth muscle cells, and they also calcify when getting exposed to phosphate. But what these investigators did was to take one step forward. Then they put in the same petri dish adipocytes and vascular smooth muscle cells next to each other. And they only exposed the adipocytes to high phosphate. And what they observed was not only adipocytes calcified, but the smooth muscles that were next to the adipocytes but were not exposed to phosphate also calcified. And then they repeated the experiment with a different sequence, where smooth muscle cells were put next to the adipocytes, and now they exposed the smooth muscle cells to phosphate and not the adipocytes. And the smooth muscle cells calcified, but adipocytes did not, suggesting that adipocytes may be sending a unidirectional signal that makes the vascular smooth muscle cells calcify. Now, what is that adipokine? We don't know. It may be leptin, it may be something else. We don't know. Of course, these data are in vitro. We don't have a corresponding, again, confirmation in animals or humans, but again, gives us some insight that adipocytes may be responsible and driving the vascular calcification. Interestingly, the same study the investigators then exposed those calcifying adipocytes to sodium thiosulfate, a frequently used off-label treatment for this indication. And what they saw was the calcification was significantly attenuated on exposure to thiosulfate. Of course, the literature is now replete with case reports, case series of positive effects of thiosulfate. But I would caution you, before we make this standard of care therapy, which unfortunately has become, that we should think about the true efficacy and safety of this medication. Although we don't have the data from clinical trial on this compound yet, the available observational data that compare patients who got thiosulfate versus those who did not in a meta-analysis do not seem to suggest that amputation rates, wound healing rates, or mortality are better with intravenous thiosulfate. In fact, any treatment that's been described, and many of us may have prescribed for calciphylaxis, does not have evidence, does not have an approved indication for calciphylaxis. So here you have cinacalcet, bisphosphonate, hyperbaric oxygen, thiosulfate. At present, we do not have sufficient data for efficacy or safety, and we should have the frank discussion with the patients. I'm not saying we shouldn't use these therapies, but at the same time, don't rely on them as the approved therapies for calciphylaxis. We and others have, of course, described this kind of a multimodal, multidisciplinary approach involving multiple specialists to target this condition. And again, this is becoming more and more common as the field moves forward. In one of the AJKD reviews, we summarized the treatment principles of calciphylaxis. Again, there is no approved therapy, but some of the treatments that get frequently discussed are summarized in this review, and you can look it up. Sodium thiosulfate side effects: nausea, vomiting, metabolic acidosis, hypocalcemia, and also QT prolongation, one of the underestimated side effects. So as part of our clinical protocol, we actually check frequent EKGs in these patients for that reason. There's a debate. Some investigators think thiosulfate is the best thing that can happen to dialysis patients, and somebody like Chuck O'Neill thinks that it's a mysterious treatment for a mysterious disease. So we started a clinical trial. Now there is a phase 3 clinical trial, multi-nation, multi-center trial, and we're actively recruiting, and I will encourage you to look up this trial. And we're not alone. There are trials now on SNF472, a phytate compound that is soon going to be coming into phase 3. There are registries. There is a beat calci trial from Australian investigators that's going to see in a smart design fashion thiosulfate, magnesium, and vitamin K as treatment options for calciphylaxis. There are a number of registries, including ours, which is the Partners Calciphylaxis Biobank, where we can actually recruit remotely. So patients don't have to come to our center, but we arrange for samples and data collection even remotely after getting a referral. Skin biopsy is debated, but when I think it is important to rule out the disease, and when it is to be done, as I was saying before, a double punch technique or a punch biopsy with a telescoping technique can be quite helpful. Imaging techniques, not really there to make the diagnosis, can be helpful to monitor the disease, particularly the technetium nuclear bone scan with methylene blue can be used pre and post to assess the treatment response. Vitamin K antagonist, of course, I talked about warfarin being contraindicated, but what about these novel non-vitamin K antagonists such as apixaban or dabigatran or rivaroxaban? Again, we are not routinely recommending this at this point, but something to think about going forward. There's a protocol for intralesional injections of thiosulfate, particularly for the localized lesions with in a distal distribution. But I think surgical debridement, and I will conclude with this point, is an important part of this care, especially if there is a heavy necrotic burden or infected skin lesions. Debridement should be considered. This patient underwent that treatment, and after debridement as well as subsequent split thickness skin graft, actually had complete healing of the calciphylaxis lesion to the point where she was transplanted and is now free from dialysis. Once a month, we also receive a patient like this, so advanced and is not coming for cure, but for pain relief. And that's another indication for surgical debridement, because that does reduce the frequency of dressing changes, the pain medications that these patients need. So to conclude, a better understanding of this disease is evolving. The current understanding is an imbalance between the calcification promoters and inhibitions. The role of adipocytes is very interesting and intriguing. There are no approved therapies. So currently, the clinical standard of care is this multimodal, multidisciplinary approach. But I think what we really need is a referral for registries and clinical trials. Thank you for your attention.